is an epidemic, and the subcontinent is expecting to explode with increasing number of patients, increasing number of individuals getting into this lifestyle disease. If you see this slide, about 30% of all global deaths in 2010 were because of cardiovascular disease, and coronary heart disease contributed the most. About more than two-thirds are the primary events, and one-third are the secondary events. And worldwide, if you see, coronary artery disease in 2004 estimate was about 5.8 million, and stroke was 4.6 million. Meaning there were 10 study which was published in Lancet gave us a very beautiful idea about the risk factors, how they interplay, how they lead to increasing number of deaths because of cardiovascular disease. If you see a person who is smoking, he is 2.9 times likely to have a cardiovascular event. If he is diabetic, it's 2.4. If he is hypertensive, he is 1.9. And if he has an abnormal ApoB to ApoA1 ratio, he is 3.3 times likely to have it. But what is interesting to see, that if he is smoking and he is diabetic and hypertensive at the same time, that is 1 plus 2 plus 3, it doesn't make him 2 plus 2 plus 1 plus 3, no. It straightway makes it threefold than this. He becomes 13 times more likely to have a cardiovascular event. And if he has all the four, he is 42 times. And if he has all the 9 known risk factors of cardiovascular disease, he is going to have a 26-fold increase in an event. So the increase in the risk is not simple arithmetic, but it's in geometric progression. We all know that age is a non-modifiable risk factor, and anybody who attains an age of 55 is likely to double his chances of getting into a cardiovascular problem. And around 55 to 64 age group, men are roughly 2.5 times more likely to have it. A study which basically addressed what is happening to the population as regards their knowledge about the risk factors and the treatment about risk factors is concerned. This was a pure study where in 5 continents, 528 urban and rural communities were assessed. And what was seen is a very disparate intake of known and proved medications to lower risk, to lower the likelihood of getting into cardiovascular events. How do we address this problem? So this problem is not only that awareness may be inadequate, the patient may not be compliant, patient may not be affording, but there may be another factor, the physician may not be aware. It has been estimated that about 15 to 20% of physicians are not aware that these are the risk factors that make difference if we control them. Not only that, there is some resistance by some physicians to give. So how do we address it? So no doubt we have to make lifestyle diet, quitting smoking, and these are antihypertensives. There's a 4 or 5 drugs that are proven effective in lowering blood pressure and as well as making a difference, and then we have statins and aspirin. Suppose we just address only one reduction, 30 to 35% risk reduction and 20 to 25%. That means just by giving 3 intervention agents having events is also increased exponentially, but if we treat them together, the benefits are also exponential. This is what Professor Lazman Sahab talked about, Professor Salim Yusuf. He is a pioneer of these drug trials. And Hope trial is one of the most famous and very important trial, which he designed from McMaster University, basically an Indian. And this is about the other doctor, about Professor Lagman Saab was talking about that Lancet study. He also gave the same message. So there is an effect on mortality if we give these drugs together. And there are many studies, we don't have time to discuss them, that if we give statins alone or we give ACE inhibitors alone and ACE alone, it favors the drug. But if they are given together, the odds ratio is very favorable for prevention. As I said about compliance, compliance is a problem. When we are giving 2 drugs, 3 drugs, 4 drugs, these days we have to give maybe even 7 drugs to pay hypertension and diabetes at the same time. And because, or he's having heart failure syndrome, and he needs probably, in addition to conventional drugs, he needs some more, maybe diuretic or maybe a beta blocker and an ACE inhibitor or an ARB combination. So compliance becomes a problem, and the compliance is a problem, not only a problem in India. Study, it was used in a polar study, and aspirin, doubtless agent to prevent coronary events. And for the people who can get benefited, those who have pre-existing disease, those without pre-existing, if they are old and have some coronary heart disease respective. And so there is a large group of people who can be potential targets for this therapy. Tips 1, I would like to tell you briefly, it had 9 arms. 9 arms because each and every drug was also given separately in addition to polypill to confirm that suppose a lipid lowering agent is reducing LDL cholesterol by 20 milligrams. What will happen if it is given in the form of a combination? So theoretically we would say that yeah, it will do exactly the same, but when a combination drug is manufactured, it's a molecule, it never has impact on BP, heart rate, lipids, and urine thromboxane aspirin is working. And of course, it was a safety and tolerability study. And these were the 9 arms. Polycap, there was a mean reduction of 7 milliliters, 7.4 in systolic case. The tips 2, of which we were also a partner, was a similar study in randomized fashion. Well, here there were regime. And this was randomized over interactive voice system all through the internet, and there were 27 centers, and just 518 individuals were given 12 weeks, 8 weeks therapy with a 12 weeks follow-up. And if we summarize, in tips 1 and tips 2, tips 2 was showing better results as regards reduction in risk factors was concerned if we are giving double the dose. This was just to confirm that if we give a higher dose, whether it will become whether it will give us a better lowering of lipids, blood pressure, as well as antiplatelet case. We will check it there and
for example, out of this you want to increase the dose of one, how do you juggle with that?
These are the limitations of a polycap. To tell you frankly, when you consider a person is suitable for this kind of therapy, then you have to also consider the dosages, the ingredients of this polycap. This is a limitation, there is no doubt. If somebody needs an individual drug in a higher strength, probably you will give it separately. You will not give polycap.
Polypill is in the market for last more than a decade now. And there are, as Alagman Sahab has said, there are some people who advocate and some are also criticizing it. And we have to see the patient whom we can sort of place this polypill. Because most of people will need multiple drugs, and probably it will be acid to give a polypill as a one. Only thing, as Alagman Sahab again pointed out, probably we have to modify the polypill. Like atenolol is probably not taken in a lower rank beta blocker as compared to metoprolol or some other beta blocker. Same is true about AC inhibitors. The patient gets cough and polyp forms. So there is to be a modification in this polyp. Other point I want to sort of also since out, I want to know beta blocker. What should be the optimum dose and sort of which will determine the dose of beta blocker which will be effective and the maintenance, how much will be the risk factor level and what should determine that dose. That is very important to know therapeutic effective dose of beta blocker.
As far as beta blocker is concerned, I don't think we can make a target of a dosage because dosages can vary. But in this study, 50 and 100 mg, both were found safe, and there were not many patients who got where we had to discontinue the drug because of bradycardia. But if you are giving a beta blocker separately, see, when we are talking about a polypill or a polycap, we are considering a fixed dose combination of 5 ingredients. It's a single capsule or a single tablet. So you are deciding that this patient is receiving this. So you will know.
Available, but they are target specific also. And the most important is the cost has come down.
Please. I don't have a question. I would make some comments really about what Dr. Khushi talked about. We know limitations of these polypills. We understand what the problem is like. And that has been pointed out by Dr. Zafar, Dr. Florence, Dr. Iftizar. Now, we need to be clear, and it seems we at this stage are not clear, that who are the people whom we are prescribing. Now, is it that a single risk factor, 2 risk factor, all risk factor, and when you say cost, we got to of the dose or minimal dose of 3 drugs, antihypertensive. That's what Salim Yusuf has done, you know about it. He has taken the minimal dose of 3 antihypertensives, in which he has used thiazides, that skips 1 study. But subsequently, in one of those studies, he has used folic acid also once, he has withdrawn it because of the cost. But taking 2 studies, and Dr. La and Bond, who also used folic acid, are we in a position on moral and ethical grounds, ethical particularly, Dr. Srinagar would tell us about the ethics of giving this patient a drug who doesn't have, you say old people, you say the risk factor. Now what about, say aspirin, we don't use it in primary prevention, do you use it?
No, not in a normal population.
So you are making aspirin for primary prevention here.
There are 2
so
studies.
You got to justify that you are using a drug on one hand and you are not using same drug which is going to be useful on the other hand. So that is one.
That is where physician's discretion comes. You see, it's the physician who has to decide. The person has to have a risk factor. He may be diabetic, he may be hypertensive. But he does not have an overt coronary artery disease. He doesn't have a complication of diabetes. This is a relatively normal looking person with either maybe peripheral vascular disease or maybe cerebrovascular disease, in a milder form. Or he could be a coronary artery disease, a stable patient of coronary artery disease. But he cannot be a patient where we have to titrate an individual drug as per his requirements. We're talking about a walk-in patient, a walk-in hypertensive patient who is 55 years old and his lipids are high. Let me refer to the...
In other words, if we can make it simple, will you prescribe it to every patient of metabolic syndrome? Then make it simpler that way. Because we don't seem to be clear.
I'm not very sure about that.
Metabolic syndrome.
I'm not very sure. Probably not. Probably not. Simple metabolic syndrome, probably not.
So which are the people? You would use it on me for my
We are using it in some patients where where we do not need titration. Yes.
There are studies from Britain where they have given to people over 50 years who didn't have all of the risk factors, possibly had one risk factor. This was only to reduce the all-cause mortality and prevent.
The study and see the risk factors. You have to look at the individual patient. And as far as metabolic syndrome is concerned, it is a risk factor for coronary artery disease. As you do it every day, you don't smoke. You see?
His BP is 150, 100 suppose. Giving him 3 drugs in post-go. When our experience tells us, I give tamoxifen to a patient with this BP, and then I see a patient drop lately. He comes with a giddy spell. I give minimum plus 2.5 milligrams. This, it is many times possible. It has happened also. So giving, say, 5 milligrams of Ibuprofen, 50 milligrams of atenolol, and also 12.5 milligrams of thiazide. How we go in first go?
This is not the patient. You have a patient where you have to estimate what is his 10-year familial risk for getting a cardiovascular disease. So if he is in the higher quartile, yes, you can give. We have shown it that it is safe and effective, and individual drugs have shown that they are safe and effective. So if you have a patient where you think there is moderate or high likelihood of a coronary artery disease, you apply the Framingham risk score. It's not difficult now. You can use your mobile phone also, and there is an application. So you can apply that if you are not very sure whether I should give it to him or not, because then it will address it will address age, it will address dyslipidemia, hypertension, diabetes, obesity, and many other factors, smoking. So you will be able to decide.
It is all majority of us.
Ultimately, it is Christian choice. He may use individual drugs, or he may make it simpler. If you think your patient is not going to be a very compliant guy, better to give him a combination treatment. If he is if he can comply, probably give 1 or 2 individual drugs and titrate. I am not advocating for it. I gave you a scientific literature, and it's for you to decide. I am not advocating any particular drug.
Experience with a cardiologist who are colleague, I cannot name his brother, admitted in ICU with us, had a discipline, went to Delhi and got his angiographic analysis done. We had given 1 tablet of benzos. Which ultimately proved the cause. So such a patient getting 3 drugs and so on.
We know that we have to know about the side effects of the drugs.
Salim Saab, your 2 points. One is the drop in the blood pressure, and another one is cough. Sir Nicholas' son, another ward, has published a study later replacing ramipril or ACE inhibitor with amlodipine, 5 milligrams of amlodipine. And if you reduce the diuretic dose, chances of postural hypertension will possibly be less. And for your kidney patients who have raised creatinine level, replace ACE inhibitor by amlodipine might be used.
But I will start with 1.25 milligrams because it is proved and beyond doubt that he is not going to prevent the progression of the kidney failure. Proteinuria, which will delay doubling and say deterioration of kidney function. And risk factor for cardiovascular disease also. So ramipril I will advocate to anti-renal failure patient. You should receive it. That would be something you should receive it.
Some issues with the polyp. First, being the students of pharmacology, how can you justify a drug of 5 drugs together? And has anybody studied the biokinetics of the drug, the distribution of these drugs in the body? Number 1. Because we believe in pharmacology, please give one drug separately. Even antibiotics cannot be given together. Nowadays there are some situations very rare situation. Otherwise, this has to be discouraged. The second thing, folic acid, selenium, calcium, vitamin D, I think they have been used for the last 5 decades. A lot of studies are there. But I think we have reached a conclusion, they don't work at all. Even aspirin has been shown to reduce cancers. But again, there is no hard, robust data to show it. Just 2 studies on just few thousand patients cannot justify using a drug on millions of people who are having one or two risk factors. I think we are aware about using aspirin itself. If you look at the benefit versus the problems like intracranial bleeds, gastrointestinal bleeds, in people who just had a one or two risk factor, you have to look at it. Metabolic syndrome, lot was talked that it caused cancer. I think if you look at the BMT studies in 2010, while the patient follow was for 20 years, and the conclusion was there is no increased incidence of cancer in patients with metabolic syndrome. I think they are evolving diseases. What Professor Lagman said, I think that is the right thing. We should try to prevent them by simpler means, what you showed in your slide also. Better physical activity, no smoking, a good diet, good exercise. I think that may be vegetables and fruit, that may be the answer. Rather than these pharmaceutical drugs about which you are not very sure. You are not very sure what is going to happen. That's very important. I don't think people should go with a message from this hall that we should start prescribing people.
It would be unfair to Salim Yusuf if we don't answer this question, that he did take into pharmacodynamics and found that giving pills together or separately, it does not really matter. That would be unfair to Salim Yusuf.
I mean, Professor Nicholson, walled out.
I have a small comment.
Any other question?
Yes. The whole thing among yourselves, I realize it's a beautifully arranged, it's a beautiful arrangement for metabolic syndrome, as I could think. Working towards all the points of metabolic syndrome, controlling the dyslipidemia with this statin, whereas on the other hand, negating the effect of a diuretic as well as a beta blocker of increasing the insulin resistance as well as the dyslipidemia by the addition of ramipril, which itself is a ACE and ARB known to decrease insulin resistance. Plus, as we already know that by the time metabolic syndrome is detected or gets converted into type 2 diabetes, cardiovascular changes have already taken place. The addition of an aspirin would itself really lead to reduced compounding events. In a way, it would be a good drug for metabolic syndrome. What do you have to say about this, sir?
Me? Yeah. I'm not very sure about metabolic syndrome. I'm not really very sure because the patients that, you see, we have to see what were the patients who were recruited in the trial. We cannot extrapolate. I couldn't come across whether there was a simple metabolic syndrome patient who was put on this. So I don't think we can extrapolate. Yeah, theoretically, yes. Practically, I'm not sure. About metabolic syndrome, I'm not sure.
I'm sure this is a very fertile subject for future research, and it doesn't involve metabolic syndrome is so common in this place, and that you will have enough number of patients to look into it, and it will be for the youngsters to really explore. In a year or two, we should have the answer whether metabolic syndrome is amenable to polypill or not.
I actually have an answer. Yes, there's one where we can use this polypill. This is for secondary prevention. Once we have an acute coronary syndrome patient like MI, who has a normal ejection fraction, who is on a conservative management, who is not going for any coronary intervention. This is a group where we need ACE, we need atenolol, we need simvastatin, we need diabetes, and who are reasonably well controlled, who have a reasonably well controlled hypertension. I think this is the group who are on a conservative management, who are doing well, who need all these drugs at least post-MI stage. with a normal ejection fraction, so that they don't fall into the group of a heart failure, systolic dysfunction. That's the group where we can use, and we are using it in this regard.